Hello and welcome to another episode of Everything Digital Health. I'm Marcus Bohr. I'm a GP in Yorkshire, and today I'm joined by Imran Khan, who is a GP in Berkshire,
Yep, Berkshire.
Berkshire, and is also the chair of the RCGP's Health Informatics Group, which is a group that I used to chair a few years back as well. So we thought we'd talk today a little bit about what the Health Informatics Group is and what it does. But first, if I can hand over to Imran to introduce himself a little further, a little bit about your
Hi.
background.
Hi, Marcus. We met a few years ago now
Yeah,
when you introduced me to the Health Informatics Group. I am a GP in Berkshire, as you said. I've got obviously I've got an interest in health informatics. I do that for a significant portion of my week now. I still do about a day in general practice, typically. I work for NSS, so that's Scotland National Services, as an
right.
informatician, and I work for Medicus as a GP, who are currently a new market entrant, GPIT
So I
system.
hear, yeah. I
So
actually used to work for Medicus as well.
yes,
Back
yeah, I
way
know.
back when, sort of when they were just getting started. So it's nice to see that they have got to the point where they are now they have customers and they are now a new GP foundation system.
Yeah,
Perhaps
they do.
that's
They have customers, they have real patients in their system. So
amazing.
yeah,
Possible future episode on GP market,
yeah,
GPIT
yeah,
and
yeah. I'd be happy.
Medicus being a new entrant.
Yeah, yeah. So that's very exciting. Perhaps the most exciting part of my week, I'd say. I think
Yeah,
it's safe to say the government organisations, including NSS, they all move quite slowly. Understandably, they have different risks, but Medicus being smaller, now much more agile, you can see results much more quickly. And I think it's easy to appreciate that once you get bigger and bigger, it becomes more and more difficult to be that agile. But it's really
yeah.
interesting. It's really interesting now to see that.
It's certainly it's great to see them, you know, get there. And as a small organisation, yeah, they can be agile. And while they have just a few practices, and even when they get bigger, they'll still be able to be relatively more agile. So if you think
Yeah,
their competition are so baked in stone, you know, they're kind of they're not really able to be agile anymore, either because they've got a very crusty old code base, or because they've got a very crusty old organization structure, or in their case, both.
and I think the other thing is that they're motivated by different things. They don't have
Yeah,
the same motivation. They're not motivated. They're not motivated to change a market. They're entrenched.
yeah,
They, and I think it's safe to say they utilize data in a way that um, enables them to corner markets, utilize markets and different markets. And I think they Optum certainly do that.
yeah. Well, that they must be aware of the value of the data that's residing within the systems, because
Yeah,
there's no way you'd pay the amount of money that that has been
yeah.
paid for EMIS just for the software, even for
No,
the user base and all of that. I think there's definitely been
yeah,
thought applied to the
yeah,
software, the value of the software.
yeah.
So yeah, interesting. Let's go on to talk about our the Royal College of GPs Health Informatics Group and a little bit about what it is. So do you want to kick us off with what is it for? What is it doing?
So the health informatics group is basically a group of health informaticians, interested GPs, and professional informaticians like myself and yourself, who used to be part of the health informatics group. They advise the RCGP on issues around information technology, information management, any aspect of technology use in general practice, data use. It's its remit's pretty wide, but it tends to focus on the more data orientated, information orientated areas of the way general practice works. it aims to provide that informed but authoritative view on how these systems operate in the NHS and in general practice.
Absolutely.
And it's providing that domain expertise that doesn't currently reside in the centre of the Royal College.
No, certainly not at the Royal College, and even in the organisations that are driving health tech, as it were. So, NHS England, as an example, um, they've got fewer and fewer people working within the organisation who have got a practical hands-on experience at GPIT. So you were talking about clinicians who also
Yeah.
have an interest in GPIT, and I think they have a few still, but those are there's been a gradual attrition of those numbers over, I would say, the last 2 decades or so, since probably a
Yeah.
peak would have been around the start of the century, and
And it's difficult. It's difficult to understand exactly why there's been a drive to reduce the number of clinicians, because they provide a view that you just simply can't get by looking at books or looking at a way a process works. It's about understanding patients, and often these are softer skills that you can't get taught by going on a SNOMED course or an informatics course. It's the subtleties of the way people work, the way processes interact with technology. All of
yeah,
that mean it's very important you have clinicians embedded in these teams. And we've seen often those teams that have close relationships with the uh, clinical teams, or have had specific clinical input, or have clinicians embedded within their teams. Their programs tend to be,
yeah.
I'm not going to say better managed, but they are more appropriate.
I
Them
think
being
that's
managed well is a different question.
that's kind of it. It's the are we building the right thing type of
Yeah,
question. Is that, if a program is announced and there's a decision to do a thing, if you've got good clinical leadership inside that team, and your feedback from the clinical leadership is this is not going to be acceptable to the profession, or it's not going to be acceptable to patients,
mm.
then that's good feedback to get early on in an agile development process. And so the whole point is that, having clinicians involved, it's the same with almost any profession. If you're building a jet airplane, you have pilots involved in designing the
Yeah,
cockpit because they're the ones that's going to use it, right? If you
yeah,
decide
yeah,
you're going to include a feature in this plane,
absolutely.
and when you speak to the pilots they say we don't need it,
Yeah,
then
so,
they're not
so
going to use it.
no, we often get compared to the aviation industry, don't we, for safety purposes?
Yeah,
But I think we should be compared to them for other aspects of design and
yeah.
integration assessment, which we're not as keen to do. I'm not sure why, but you're right. You look at uh, the way uh, I was watching a program. My son likes any form of transport, and we were watching a program on the Dubai airport, and the way they test and assess service planes. There's pilots involved
Mm.
throughout all stages of that redesign, redeployment, after errors, after problems. The pilots are involved, and I don't think the NHS and clinicians should be any different.
No, absolutely. This is I do draw the aviation analogy quite a lot actually these days, because I have got onto this concept of clinical safety, but in terms of the interfaces. So I know we talk
Yeah,
about the
yeah,
aviation safety parallel is hackneyed, but the the user interfaces, as you move from one NHS trust to another NHS trust, you're expected to use, as a clinician, a whole range of different interfaces, and they're all
mm,
brand new to you in the new trust. And if plain cockpits were designed like that, then you wouldn't be surprised if there was a crash every week,
no,
because what used to be a red lever to put the landing gear down between the seats or something, now that's the third menu deep on a context menu,
yeah,
and you've got to right click, and it's not easy to find. That level of difference between the user interfaces that we are expected to use in clinical medicine is absolutely critically dangerous. And it means we don't have the ability to train undergraduates, for example, on a
No.
standard user interface. I think another good way of bringing it into sort of common language is to say, well, when you learn to drive a car's interface. That's what you're doing. And the interface is you have a steering wheel here, there are some controls either side of that, there are some pedals that are always in the same order. The steering wheel always has the same relationship between where you turn it and how it steers. And the mirror is always in the same place. And yes, some of the other controls, the less important, the less critical controls, do move around a little bit. But by and large, the key function of a car cockpit stays the same from one car to the other, which is why I could get in your car and drive it, and you could get in my car and drive it. And we've completely thrown that out in terms of clinical user interfaces, because if you go from one trust to another, or even from one GP system to another, there's such a wide difference between how the layouts work and stuff. And yet you'd be expected to function at 150% on day one as a new registrar, for example, moving from one trust to another. And it's absolutely terrifying when you start thinking about what could have been done, how good it could be, and where we are now.
But I'm sure if you talk to some of the suppliers like Epic, Cerner, etc., they will say their user interface and their user design is designed so that you could pick it up on day one and work it out. And in fact, I'm sure they would now even say, we've done so much more of it for you. You just have to talk, and
Mm-hmm.
it'll capture everything that needs to be captured. So I think there's that element of actually, perhaps you should think about not driving anymore. We'll do that bit for you.
Well, I mean, maybe if it's going to be that good in the future, then we won't need these interfaces and we can all stop whinging. But I think there's always going to be some element of having to interact with the computer using a non-voice interface.
Yeah.
Um, for example, like prescribing, um, it might be a while before we've got some systems that are so good that you could say, this is what I want to be prescribed, and it will unerringly check that in the BNF for you, present you with a dialogue that says, this is what I think you want to prescribe. Might even check the formulary. It could be great. I mean, this feature, I imagine,
Oh, great.
it
I
could be
wish I had
better
that.
than what we've got now, because it could do a whole load of checks and say, oh, hang on, you're about to prescribe an antibiotic, but we know that there's a 40% community resistance to this particular antibiotic for this particular condition. Wouldn't you rather prescribe this other one, which I've also checked and is definitely the recommended first line antibiotic for this condition? That's the kind of SatNav of medicine that we need.
Yeah.
But I'm not sure that we're going to get that, and even if we did, it wouldn't be ubiquitous. And
No.
and if it's not ubiquitous, it's not like a car's user interface, you know. So
No. No.
these are the kinds of conversations that they have been having, you know, at the Health Informatics Group for 25 years, really, since it started. So you know, it's a group for uh, experts in health informatics, but also the change makers of health informatics. It's people who want to be critical and say, why are things not better, kind of thing.
We have this conversation, albeit about a product or about a service or a API, in exactly the same way. What are we trying to achieve? What could go wrong? What are the implications of doing it? And we'll often find that because we're a group with literally hundreds of years of experience, and some of these programs don't have that experience. There are
Yeah.
sometimes small things, sometimes big things, sometimes things they've thought of we haven't. That allows the group to be quite. I think it's been quite effective in terms of helping the programs understand what they need to do to make it a successful product, whatever the product is, whether that's a service, API. whether
Yeah,
that's
yeah.
a new pathway. But it's all those things, and I think the Health Informatics Group is part of that conversation.
Yeah. It's definitely what got me involved more deeply in GPIT. So my journey to getting to being eventually the chair of HIG was I qualified as a GP in 2011 and was working as a GP, sort of locuming various different places. But all through my training, I'd been quite disappointed with the quality of the GP systems I'd used. And just as it happened, I ended up the training practices I was working in. The first one used something called Torex Synergy, which has now left the market. It was already on its last legs when I was using it back in 2010, something like that. And then the next practice I went to used Vision, which is, of all the primary systems, is kind of the oldest looking. It looks very sort of Windows 95. It's quite laggy. Everything's a bit busted, you know. So I had the worst two systems. And I was kind of thinking, hang on, everybody told me when I was in hospital that, you know, GPs have got these great systems and they can do all the stuff that you want them to do. And I hadn't any experience using those systems. I have since then used, you know, EMIS and System One, and obviously I worked for Medicus, and so I've, you know, broadened my experience a little bit. But I remember googling like who's in charge of GPIT, and very naively trying to look for who's in charge, and then I found the Health Informatics Group, and there was an email address for the chair at the time. So I emailed the chair, who was a lovely lady called Libby Morris, and said, "Hi, I'm a GP that's just qualified. Can I join?" And she was like, "Yeah, sure." And we met up to say hi, and I think she was kind of vetting me, that I was kind of a fit and proper person, and then joined the HIG. So I came along to a couple of joint GPIT meetings, um, and got more involved. I joined the Primary Healthcare Specialist Group, which is a subgroup of the British Computer Society, and I would recommend people join that as a good way to keep up to date with GPIT. Um, and I just kept along, kept coming to the meetings, and about 10 years later, I was the chair of the group. So, you know, these things, you know, there was a black spot kind of thing, isn't there? At some point,
Yeah.
because the workload of chair is incredibly high and is unpaid. So, as you are probably experiencing right now, it gets handed down with a kind of resigned, "Oh, I've had enough now. Here, you take it," kind of feel.
which which is not the greatest position, to be
No.
honest, for a group that is seen to be authoritative and does provide. And we're asked for advice. So if we're asked for advice, it means somebody's valuing our advice.
Yes.
It's
Yeah.
not like they're ignoring us; they're coming to us for it.
Yeah.
We have people regularly emailing us from NHS England, from other arm's length bodies, from the college, from the BMA, asking us what we think. Now, there's a limit to the capacity that a voluntary organisation
Yeah.
can do. That's just the way that's just life. We have other roles, we have other commitments. Um, uh, uh, Tom and I and you have have advocated for a long time that this this role is really important. It still has influence and navigating a way through to a way
Yeah.
that's sustainable and effective, or to remain effective, is difficult. Doesn't mean we don't stay effective. We stay effective because we're still part of the Royal College of GPs, and for whatever reason, rightly or wrongly, that's important. And I
Absolutely.
think until that changes, I think that the group is still important.
Well, that is it. I think lots of royal colleges um, have special interest groups, and those special interest groups are often very small, and you know they're often li- they're relating to some fairly small aspect of care. Um, so, for example, the RCGP has a Lyme disease special interest group, I met the team of them people one time. So they're constraining, they are the experts on general practice or primary care management of Lyme disease, and they've become experts on that. But the workload that's going through their group is probably only small, and so it's not unreasonable that they might do it as a voluntary act. And across the whole of the medical profession, a lot of this work is done as a voluntary thing because it just needs to be done. And there's an assumption that, well, GPs are, clinicians are being paid well enough anyway from their main job, so it's fine for them to just do, a 2 hour a meeting and a bit of a PowerPoint or something after work. But where that starts to fall apart is if you're chair of a group and then there are, say, 50 other organisations asking for the advice of that group. And I know that when I was chair, we did a list and it was like 50 or 60 other organisations or other programmes, and it's probably more now for you, that as the explosion of post-COVID digital programmes has continued, it's not feasible to be dealing with this enormous list of acronym organisations where, from HQIP to the National Child Measurement Programme to NHS EDIX, GMC, and there's so many organisations that we end up interfacing with.
I think that's it. It's the broad nature of its remit. Yeah. Almost everything has a digital element, and the digital element comes from an area of minutiae, from a template in a JGPITC system to large contract changes involving online consultation, which is going on now. So what are the implications of leaving online consultations on? What happens to safe workloads, etc.? All of that has huge impacts on every GP across the country, and we are being asked to comment on that. So there's been numerous programs since I've been chair that have implications for all of general practice. Now, and I think it'd be safe to say, whilst I recognise that it's really important to have a Lyme disease special interest group, it's not a competition. I'm just saying that their remit, their requirement is lower.
Yeah, the number of decisions that they're going to be asked to make and the effect that would have on the rest of the profession is just less. And we could have chosen any special condition-specific group or something like that.
Yeah.
But when you've got broad special interest groups, and it's not just health informatics, actually, safeguarding is another good example. So there's a safeguarding special interest group. And of course, lots of things that happen across the whole NHS have dramatic implications for safeguarding, and the decisions that are made and the advice that's given by the safeguarding group have massive implications across the whole NHS, but they are not resourced either. And I do think we're getting to the stage where there needs to be a proper debate about, if we're going to have professional oversight groups, how are those funded? Because we didn't manage to solve it during my tenure. I was handed the same problem by my predecessor and his predecessor and his predecessor. The amount of stuff we've got to have an opinion on is just expanding all the time, and the implications are huge, and yet there isn't really a robust way of funding this. Answers on a postcard. If you have the solution to this, please comment below.
It's an understandably difficult problem. Joy Shacklock, who is the safeguarding lead at RCGP, and obviously I've been close to Joy over the last few years, because there's a huge crossover between online access to records and safeguarding.
Yeah.
So we've been, and I've known Joy for 4 or 5 years now, maybe longer than that now. And you understand that a huge amount of her work is also digital.
Yeah.
Because it's about information sharing, data sharing, access to services, access to shared care records. All of this has a digital component. All of this has a potential safeguarding component. So there are areas that you would have thought could be better resourced in a more sustainable way. Again, Joy will admit to anybody that comes under a lot of pressure because of the amount of things she's been asked to do.
Yeah.
Again, because safeguarding is quite varied in terms of its scope. It's quite wide in terms of its scope. So
Yeah.
I wish I did have an answer, but
I
it's difficult.
perhaps we need to look at how the aviation industry, since we've mentioned it, approaches this as well, because they must have different layers of statutory oversight. There are going to be, say, professional pilots who work within the Civil Aviation Authority, and they're going to be pilots working direct as commercial pilots, and they're going to be people working in other parts of oversight and making guidelines and things like that. I wonder how they structure that and how they fund that. So, maybe we need to delve into that side of things to see whether there's something we can do about it, because certainly at the moment it feels like we're under resourced to deliver the amount of oversight that's needed, and yet there really is a need for oversight, because we know that a lot of these programs go wrong very, very quickly. And just to pluck a few out of the last couple of decades, we saw the National Project for IT went wrong, collapsed, did not really release any of its benefits. The GP data for planning and research project that blew up in the summer of 2021 and caused a bit of a furore about essentially GP data being extracted, and its predecessor, care.data, which also blew up and caused a whole load of people to opt out of any data sharing for secondary uses outside of their medical record. And it's like, so things go wrong. There's clearly a need for good quality oversight to help more of the programs be done right, because there are good reasons why you want to have data sharing. There are good reasons why NHS England should have access to some data so that they can plan the management of the health service. There are good reasons why researchers want to research using the data that's in medical records. And there's a right way of doing these things that's legal and respects people's privacy, and there's a wrong way. And the people who stand between the right way and the wrong way is people like us,
Yeah.
on those committees.
Yeah, totally. I was part of. I joined the Health Informatics Group having been deputy chair and a specialist member at something called what was then iGuard. It's now the Advisory Group for Data, which oversees any dissemination of health information from NHS data sets, including those under for consent, those for statutory purposes, those that require particular oversight or for internal uses. So obviously, my interest has been data and information governance, GDPR. That is my. But it is huge. I don't think people understand quite how much their own data is moving around, how important that oversight is to prevent it from being used inappropriately, how
Yeah.
important all these governance layers are to ensure that it's being used safely, doesn't go into the wrong sphere, if you want to call it that, not being used for commercial purposes beyond which a consented patient may have consented, or a consented cohort may have agreed. All these things are complicated, and
Yeah.
then if you move into GP data, we've both seen GP data programs fail because they failed to communicate what they were trying to do in an effective way. Not exactly that the premise was incorrect, but they didn't express what they were doing, how they were going to do it, and what effect it would have on them to a level that patients were was satisfied, and that's basically what happened. That's basically what happened with GDP, GPDPR,
Yes, it
GP,
started to
yeah,
go. I
planning and
can.
research. There's so many acronyms, like you
Well, it
said.
doesn't help that the general direction on the GDPR.
Yeah,
I've
yeah,
completely
it's
forgotten what
even
even that.
worse. You'd think they would have chosen a
The, the
different.
EU GDPR got confused
Exactly.
with the GPDPR, and
Yeah,
this. I mean, it's insane, isn't it? Really.
yeah,
Um,
yeah,
I'd like to just bring us over to the Joint GPIT Committee because that's something again. When I Google searched the Joint GPIT Committee, I got nothing. There might be more now, but I remember when I went to my first meetings, I had no idea that this committee existed. Um, but it does exist, and it has a relatively large amount of power, especially
yeah,
when you compare it to other areas of clinical medicine where clinical voices really are only advisory. So you might have a workshop or something, and clinical feedback gets taken into account. But the Joint GPIT Committee is a joint committee of the BMA and the RCGP, hence joint, and it's about GPIT. And
yeah,
it's co chaired by whoever's the chair of the BMA's IT committee and whoever's the chair of the RCGP's IT committee. And the great thing is, it's mentioned in the 2004 GP contract that there has to be an oversight committee. And that's what the Joint GPIT Committee is. It's an oversight committee for everything that could conceivably affect GPIT. And the reason it's in that contract is because at the time we were moving from GPs as individual businesses paying for their GP computer system themselves direct as a customer of TPP, for example, or EMIS. And we moved from that to an arrangement where the government would buy it for everybody. And because we were no longer the customer, in a very savvy way, we said we have to still have a voice and be listened to. And so this joint GPIT committee has teeth. Like
yeah.
it has kind of veto. It has power to be able to say no, that's not happening. You cannot do that to GPIT, to our patients' records, or you can't take that data, you can't change this user interface, you can't make that dangerous change. So it's amazing that, to me, that isn't more widely known across general practice as a whole and across the profession as a whole. This is what we should be going for everywhere. Like every part of medicine needs to have clinicians with veto over how the IT works. And if you don't have a veto, you might as well not bother.
And I think the way that the joint GPIT operates, um, it and under the contract that you were talking about, how it was established, it they are seen as, although it's an oversight committee, it doesn't have the authority to say in NHS England you cannot do this, but it does have the authority to say we don't think this is a good idea. We're not supporting this. You're on your own. And I think that is powerful, regardless
Yeah.
of whether this is underpinned by this year's GMC, GMS contract, maybe PMS contract, wherever. It's that power that has been established over the years that it has real authority.
It's what you call soft power, I suppose, isn't it? It's
Yeah,
being able to
it
say
is.
we think this is a bad idea. We
Yeah,
don't support it. If you want to implement it against our advice, then you're responsible for the consequences. And that
yeah.
sometimes is enough then to just make people think twice about whether they really, really wanted to do this in the first
Or
place.
reconsider the cadence in which they implement something.
Yeah.
Ralph Sullivan, myself, and Joy were probably a thorn in NHS England's backside for near 2 years for the accelerated access to patient records. But I don't regret a second of it because I think every every improvement in that project meant it was safer for patients. I'm still not a huge believer in it, in the way it was rolled out. I think I'm your biggest advocate of online access to records for a patient. but only if it's done in the right way.
Yeah.
I still don't think it was done in the right way. Well, that is on record. But that again, we advised. They took on board the advice. They changed a lot of what the program was about. They didn't change everything, but that's life, isn't it? You can't expect everything. There are certain things you can and can't influence. But it was a lot safer, and I think Ralph and Joy will admit it's a lot safer than it could have been. And I think, yes, we couldn't
Yeah.
stop the entire program, and part of me didn't want to, because I just wanted to make it safer. So
Yeah.
there's always that tension between saying no, 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 and being more pragmatic. And I think as the RCGP, we can avoid getting bogged down by whether we're in dispute, and we can bring it down to the basics of whether we think it's a good idea.
It's much more about quality and safety
Yeah,
and the standards that we're setting,
yeah,
rather than any sort of
political posturing
commercial or
or
political side of things.
influence.
But my involvement in Joint GPIT committee was my first taste of the politics that does exist when you get to certain levels of, uh, of how this health system works. Because I remember being quite surprised. I suppose I shouldn't have been surprised, but things that are said in Parliament, for example, or a ministerial commitment, or even a prime ministerial commitment, as it was with online access to records, that trickles down through the system, and it puts a huge amount of pressure to get something done. I mean, I don't know why, because the ministers themselves don't give a toss about changing what they've said, from a manifesto commitment to we're not going to do it. They don't seem to be in any difficulty turning on a dime and changing their tune. But for some reason, the civil servants below them and the rest of the machinery seems absolutely hell-bent on doing things because a minister has decided that it should happen. And whilst a soundbite kind of policy thing might work for 95% of the population, we as clinicians have got to think about the harm that might be done to the 5%, or it might be a larger group or a smaller group. But in this case of online access, for example, we were thinking ahead about the harms that could come if a abusive partner, for example, can get access to someone's online record. If you make it very, very easy to get access to an online record, now that abusive partner can see everything that
Exactly.
the person he's abusing says to their GP, and that's supposed to be private. Now, there are appalling consequences that you don't need much imagination
No.
to come up with some horrible scenarios affecting women, children, people who are in modern slavery arrangements, illegal immigrants. There are a huge number of vulnerable groups, and we as clinicians are there to protect them. And we're going into battle with no resources against the entire governmental apparatus and a ministerial commitment to do it. And that's the reason why we need the independently resourced oversight groups. Because if we were funded by NHS England to oversee NHS England, you can immediately see the problem there is that they will just dwindle the funding, turn it all off. I mean, you could argue that that's one of the reasons why we're still not funded. It's a form of regulatory capture. By not funding the regulators, you just make it so we're incapable of being competent. We're incapable of keeping up with the volume of work because they're just not funded.
Yeah,
But
and
how
I
you
think
fund it?
the BMA fund it in a different way through both the, their membership strategy and the way they see IT as a pivotal part of their contract negotiations. They have for many years now, and I think we don't, because we don't have that. We don't have that political pen to push in that respect. We are all about, like you said, the standards, the guidance, the quality.
Yeah.
We're our political desire is slightly different. That doesn't mean we don't want the best thing to happen. It's just that
It's
It's
a nice
different.
arrangement because it means that we can focus on the areas that we're good at, the qualities and standards and that sort of thing. And the
Yeah.
BMA trust our voice as well. They often want the RCGP to get involved to advise them on GPIT matters. The BMA have got a defined remit, which is pay and rations. You know, it's like making
Yeah.
sure that the business model of general practice isn't undermined completely. Um, and the government have got their role as well. You know, they are providing the service, and they're so it can work well. But I think there's got to be some redistribution of how that oversight system works, kind of thing. And at the moment, I don't think we have got that right. It would be nice to see that solved. You know, within your tenure, um, but
Um,
it's hard to see where it's going to come from.
I remain hopeful. I think positions like this. I think Royal Colleges, like the Royal College of Physicians, they are able to leverage the way the consultant contract operates to get skilled informaticians to do work for them because they understand it's part of their contract to undertake a professional activity that's in their interest. And if their interest happens to be informatics, then they can get paid for it.
Mm-hmm.
We don't have that contract in general practice. We can't leverage that contract in any way. So it's got to be either the Royal College themselves who pay us or somebody else. And I think you've highlighted the difficulty with arm's length bodies or NHS England paying us directly, how to remain truly independent
Yes, that's the thing.
and be and voice our concerns in a way that isn't constrained by whether they may continue to fund our oversight is the trickiest aspect.
Yeah. Well, the Faculty of Clinical Informatics were the ones who learnt this the hardest possible way, which is that they put out a federated data platform position statement.
Yeah.
I think that was probably around 2022,
Yes.
and it was a very balanced document. Interestingly enough, it was very much a kind of balanced appraisal of the pros and cons of using that company to do this work, and the work itself and how that was going to be done, and they set that out, and very shortly afterwards their funding was withdrawn from NHS England. I am told that their kind of fate was sealed already at that point, but it didn't help in their last ditch attempts to get some emergency funding, because it's like, well, if you're going to publish position statements that embarrass NHS England, then NHS England is not going to fund you anymore. And we're seeing exactly the same thing happen, history repeating, with the PRSB, so the
Yeah.
Professional Record Standards Board body. They're about data standards. They were formed at least 12 years ago now, to help with interoperability between computer systems in the NHS. NHS England has decided to stop funding them because it's convinced that it can do all of that interoperability work in-house. That's what they have decided that they're going to do. And I think the most unbelievable part of all that is that NHS England themselves are going to be they're going to be dissolved and absorbed into the Department of Health and Social Care. So they say they can do all this standards work, but they don't have the people to do it. And at the same time, their organisation will cease to exist.
Yes, it seems a tall order to both cut your staff or cut your running costs by 50% and do all this work, take all this work in-house and reorganize the
Yeah,
entire organization into the Department of Health
yeah.
within 2 years seems
It's
unlikely to
impossible
me. And
because
what happens in that interim period? Standards will fall.
yeah,
There will be things that are missed. Programs that should be going ahead won't be going ahead. And it's not clear that there was any thought, particularly the PRSB, behind how
yeah.
they were going to achieve over that function within DHSC.
Absolutely, it's not been thought through, and as you say, standards will fall. Um, the My experience of these big reorganisations of the NHS is they provide no net benefit. They happen every 2 to 3 years with a regularity, and they take up 100% of the resource in the organisation while they're happening. So nothing new will come from an organisation whilst it's undergoing a reorganisation.
No.
And I know, I know that your own organisation, Bob ICS, undergoing a reorg at the moment, and of course the ICSs are all having to cut their costs. During this period, nothing is happening. Meetings start with people looking after each other and asking whether anyone knows anything about redundancy, and then nobody does. And but it's a paralysing situation for organisations to be in. NHS England is paralysed. The ICSs are paralysed, and no one is seemingly talking about it. I know it's a little bit esoteric for the mainstream media to get their heads around, but these are the bodies that are meant to actuate. They're meant to be the movement, the way that NHS things get done, and none of them are functioning.
I mean, I could talk endlessly about the NHS England reorg and the ICB reorg, but it strikes me that in order to get from A to B, you need to have a transition plan. And they seem to have missed the transition plan.
Hmm.
They seem to have thought B seems to be like a nice position to be in. Let's just go to B. It's like getting
Yeah.
in your car and forgetting that there's 500 miles between you and the Highlands, and you didn't fill up your car, or you didn't MOT your car, or
And
you
didn't plan a
decided,
route.
yeah, didn't plan the route. You ended up in Wales. Because if you've got no plan, then how are you going to deliver it? I really, I mean, obviously,
Yeah.
I could go on endlessly, and I think all us, I can speak for the staff who are trying their best to achieve what they can, but it's understandable that everything freezes because understandably managers are not sure how they're going to deliver programs, how they're going to fund programs, where the funding is going to come from. So immediately everybody's on the back foot. And this extends all the way up to the joint GPIT committee where we have people present. They go, we're not sure of the trajectory of this program. What we thought we were going to ask you, we're not sure we're going to ask you now. This has been paused. Not sure we're going to deliver this now. So it has an effect on every aspect of
Hmm.
the NHS at the moment. Really does, because all those people who are delivering programs, I mean, it could be anybody from those delivering API access to PDS in NHS England to people working on the NHS app. They're all in the same boat. It's understandable that they're not as focused as they were,
No.
and that's completely human.
It is, and that's what happens when you send a massive shockwave through an organisation like that, and also one that's lasted so long because it was announced at the start of the year. We're at the end of the year and nobody knows any further about what's going to happen. So that's an entire wasted year of people working at about 10-15% of their normal efficacy because they're spending a lot of their time worrying about, if I get made redundant, what's my next job? So I need to have my CV in order. I need to make sure I'm
Yeah,
doing training. I don't know what I'm going to be doing about this aspect of my job. And it's also difficult to care about something if you know
yeah.
that there's a good chance that you won't be in that team next year. How do you
Get
really
motivated.
get motivated to get stuck in? You can't. You're not going to. And even more demotivating is when the actual program of work may not exist in a year's time. So it's not even as if like this team will exist, but I won't be in it. It's just like
Yeah,
not all this work will have been.
funding's not there, so
Yeah, they'll
whatever
just
happens.
get an enormous Microsoft shovel and shovel it into a SharePoint somewhere, and then switch off the SharePoint, and it will just disappear into the ether. And all that work and effort and thinking and time and consultation just disappears. Um,
Sometimes it's worse than that. Sometimes they put it in SharePoint and leave it there on, not being touched, not being updated, links broken, things
yeah,
not
well,
working.
my advice to everybody now is, if you've got good pieces of work that you're proud of, put them in your own personal GitHub.
Yeah.
So open source them, and I guarantee that even the most aggressive dickhead of an organization can't really criticize you for sharing a document,
Good practice. Yeah.
that, sharing some good practice with the wider NHS. And it also means that it's under your control, not the organisation's control. So you we need more sharing of good practice anyway, instead of every single body of the NHS doing things again and again in silos. We should have
Oh,
more
yeah.
sharing. And so this also means that when the organisation ceases to exist, rebrands and deletes its web pages, you've still got access to the good work you did in your last role. And I think that is what, in the software development world, to a lesser or greater extent, that is something that people will do. Obviously, if you're working on closed source software, you can't exactly just like take a copy for yourself. But if you're working on open source stuff, you would always be sharing that portfolio of work as widely as possible, because that is your business card of like what you're capable of. It also
Yeah.
means somebody else doesn't have to solve that problem if you've already solved it.
Yeah, precisely. Obviously, part of my role now is with Medicus. They're not open source. Understandably, they have commercial
Yeah,
requirements, and I'm torn sometimes. But what I can say is that they work incredibly hard to try and achieve something that others have not managed to achieve, and it costs money because the NHS machine is difficult to go up against. Whether that's through a method of doing open source development or a commercial arrangement like the new market entry program, the NHS England is a difficult beast to understand.
yeah.
It's expensive to understand it. It's expensive to engage with it.
It's a
Um,
very difficult customer to sell into.
yes.
They And especially as a smaller organisation, even though they have tried very hard at the centre to be more open to working with small organisations, I still feel as though there's a lot that needs to be done, because if you don't have the money to tender, if you haven't got the money to put uh, a 12-person team on a tender to pitch for a certain amount of work that's coming up,
Mm.
you can't be part of that work. So even though it's meant to be SME friendly, but it kind of isn't. Um,
I think they've tried to make things easier with frameworks and being on frameworks, but
hmm,
it's still, you, the large organizations can incentivize in a way that others
yes,
can't. And we've seen that with many, many products, including the numerous AVT or ambient voice technology companies out there who are so well financed by their venture capital, and the possible gains that they may gain, that they can almost do anything they like. They're
yeah,
not limited by the bounds of what they have to sell as a product. It's just about getting into a market.
yeah,
And I think that's a world that small SMEs can't compete with. Impossible.
yeah. It would be lovely to finish on a sort of a little bit of an up note, having talked about some of the negatives, and I was just going to talk about the primary healthcare specialist group, which has its conference next week.
Does indeed.
So I'm going to be there.
Oh, I will
Um,
see you there then.
so yeah, it's going to be good.
Yeah.
It's a nice, very friendly group. I'm going to plug them because I think it's a group I've been involved in for at least a decade, and they were very helpful when I was starting off in GPIT. It's a small and friendly group. It contains people who work in industry, in government. We've got normal jobbing GPs. We've got people who work for regions, like the Scottish government, for example, NHS England, but we've also got experts with specific expertise in terminology or data structures and things, and just jobbing GPs who want to get better at using their system. And so there's a really wide range of expertise there, and there's some interesting talks always, and they have a free education day that happens the first day of the conference, and then they have the AGM, and the conference is the second day. So that's the 13th and 14th of November 2025 at Hollins Hall in Bradford.
Yes, it was excellent there last year. It was very, very well attended. It was exciting.
I missed it last year. I had actually booked to
Yeah.
go, and then for various reasons was just so busy with other work that I couldn't really take the time out. But this year is a little bit more chill, so I'm able to get there, and it would be nice to catch up with people. In
Yeah.
fact, one of the reasons I ended up doing this YouTube channel is because of that group, in that I would go to that group and I would meet these people who are incredible range of expertise, and yet very little of it's written down anywhere.
No.
There are very few textbooks of clinical informatics. There's a few opinion pieces. I know there's a few books you can get, but there's nothing that you could call the Oxford textbook of clinical informatics. Neither is there the
No.
Oxford Handbook of Clinical Informatics, the kind of little cheese and onion version. That
Yeah.
There isn't much out there, and
No.
there isn't an awful lot that you can. There's not much on the internet. There isn't much in the way of YouTube channels, and I was starting to see these people retiring. You know, a whole half a generation of them retired since I've known that group, and I was thinking, well, they're just gonna. They know everything there is to know about, I don't know, cross mapping CTV3 into SNOMED and stuff, and then they're going to retire and no one will have that knowledge. And whilst some things just become obsolete in terms of technologies, it's still nice to be able to know how these things were done. And so I wanted to record some of it, and it was actually at the funeral of another GPIT stalwart, Ewan Davis. That was last March, and I was chatting to people and saying, we really need to do something like this, and they were like, yeah, you should, Marcus. So I ended up being the one who ended up doing it, and I thought, well, great, I can bring on people and talk to them about this stuff, and then it's captured, it's there permanently on YouTube, so that people can talk about it, and that it functions as a place to record some of this information. So
That's a great way of putting it. But yeah, I totally agree that there are obviously the colleagues of ours that, including those that are still part of the Health Informatics Group, that have immense amounts of experience and knowledge, not just of health informatics, but of general practice as well. So, I mean, it's a great place there's lots of both new technologies, old faces, lots of experience, lots of interesting people. Really good, and I think coming under the British Computer Society is a great place for that group.
Absolutely. So
it's the right place.
That feels like a nice point to wrap up. We've talked about the main GPIT kind of committees and bodies that exist: the Health Informatics Group, the Joint GPIT Committee, and the Primary Healthcare Specialist Group.
Great.
So
Can I plug the Health Informatics Group?
yes,
Obviously, any members of the Royal College who want to get involved, think they might be interested. An easy way to see what we do and to get involved is to have a look on the forums, which I understand Marcus manages and still holds dear. So please get in touch with either myself or my deputy Tom Nichols, and we'll help you. We'll guide you through getting involved. And if you want to get more involved with a committee, etc., more than welcome to do that as well. So just get in touch.
I will put the links to get to the forum in the description.
Great.
So just remains for me to say thank you very much, Imran, for joining us. Been fantastic to chat to you, and as always, every episode gives me more ideas for future episodes. So there's definitely a one that we should bring you back on, talk about state of the GPIT market and how it got there, and what Medicus is doing about it, which should be quite interesting.
That'd be
So
great.
thank you very much, and goodbye.
Thank you. Bye.
Bye.